Hey everyone, hope you all are doing good. My name is Tejas and today we are going to talk about cardiac pathologies. Okay, let's talk about ischemic heart disease. Before that, let's define what ischemia is. So, ischemia is whenever you have reduced blood supply to any organ. Okay, as seen in this figure, we have a atherosclerotic plaque here, and this plaque results in substantial narrowing of the coronary arteries. This is coronary artery. Okay, and this is what we call ischemia. Now, one term that you can get confused with is infarction. Okay, so let's define what infarction is. Infarction is when you have sudden abrupt discontinuation of blood flow to any organ. Okay, so the blood supply is abruptly cut. Okay, so the organ can undergo necrosis in this case, and in case of ischemia the organ which the arteries are supplying can still survive, okay, with reduced blood flow. So that's the difference between ischemia and infarction. Now let's discuss what ischemic heart disease is. So ischemic heart disease is when the coronary arteries are narrowed down due to underlying pathologies. The most common cause of narrowing of coronary arteries is atherosclerosis. Atherosclerosis is nothing but a plaque formation within your coronary artery lumen that reduces the blood flow that's going to your heart. Okay. So now some sources says that the number is 75%, or some sources says is 70%. But for this lecture, we are going to stick with 75%. What that means is that if you have your coronary artery, unless and until the coronary artery is 75% occluded with the plaque, the heart will continue to function normally. Okay, so whenever you have more than 75% occlusion, that's the time you start seeing symptoms in the patient. Okay, now let's see what are the symptoms of this. So you see chest pain, angina, and dyspnea. Let's see why you see dyspnea. So for example, this is your heart. My drawing is not that good, but still. Okay, so this is your right atrium, this is your left atrium, this is your right ventricle, and this is your left ventricle. Okay, and here are your lungs. Let's say your lungs drain your oxygenated blood into your left atrium, and from left atrium it goes to left ventricle, and then it goes to systemic circulation. Okay, so whenever you have an ischemic heart disease, the blood supply to your left ventricle will be reduced, so the left ventricle will not be able to push the blood into your systemic circulation. So what it will do is there will be backup of fluid here to the lungs, and this can cause pulmonary hypertension, which will manifest as the patient being dyspneic or have difficulty in breathing. So now let's see what are the coronary artery disease equivalents. So what this means is that if you have two patients that comes to you in your clinic, and one of them has a noted coronary artery disease, and one of them has either diabetes or your chronic kidney disease, so the chances of them developing ischemic heart disease over their lifespan would be same. So this is important, that coronary artery disease equivalents are diabetes and your chronic kidney disease. So all of them have the same level of risk of developing into an ischemic heart disease. Now let's talk about the types of ischemic heart disease. You have stable, you have unstable, you have your NSTEMI and your STEMI. Let's talk about stable angina first. So stable angina is chest pain that arises with exertion or emotional stress. So whenever your body demands more blood flow, and that puts your heart muscle at stress, so whenever the heart muscles needs more blood flow in order to function, you see the symptoms of your stable angina. In this case, as I said, whenever you have plaque that occludes greater than 75% or more of coronary artery, that's the time you start to see symptoms in the patient. This is your typical chest pain that occurs with exertion and is relieved by rest and nitroglycerin. So whenever there is exertion, obviously your cardiac muscle has to do a lot of work, and that will need them to have increased blood supply. Okay, in this case you have your coronary artery that is already having a plaque, so the blood supply is reduced, and that's the time you see your stable angina having symptoms. This is relieved by rest. So obviously if you will rest, your heart muscle will demand less blood flow. And nitroglycerin. So what nitroglycerin is a drug which is a venodilator, So whenever the patient takes nitroglycerin, his or her veins will start to dilate. When the veins dilate, as we all know that the veins eventually go and drain into your right atrium, right? And then from right atrium to right ventricle, then right ventricle via your pulmonary tract to your left atrium and your left ventricle. So whenever the veins dilate, that means that the blood will stay in the veins and there will be reduced blood delivery to the right atrium. So what that means is that the preload to the heart will be reduced. So what is preload? Preload is basically the amount of blood that your cardiac muscle expects in order to put back into the system, and it pushes the blood against an afterload. So in this case, nitroglycerin works as a vasodilator, and this reduces preload to the heart. That is a fancy term for saying that the amount of blood that will go back to the heart will be reduced. So when there is reduced blood flow, the heart has to work less in order to push forward that reduced blood flow. Okay, let's say if the heart gets 100 ml of blood, then the heart has to push 100 ml of blood. It will require more energy when compared to 50 ml of blood. So that's the basic logic behind this. So in this case, stable angina, EKG and symptoms at rest are unremarkable. As we know that the patient already has normal blood supply at rest, the symptoms are not seen. So what will you do if a patient comes to you and he says that I am having chest pains when I do some exertion or any physical activity? In order to diagnose this, we do something that's called a cardiac stress test or a pharmacologic stress test. So defining the cardiac stress test, in this you tell the patient to walk on treadmill for 15 minutes, 20 minutes till the patient till the patient does more physical activity and you see the symptoms of stable angina. And at that time you do the EKG and you see ST segment depression as mentioned in this picture here. So this is your P wave, this is your QRS, and this is your T segment. So in this case you can see that the ST segment has been depressed. So what does ST segment depression suggest? So let's see, if sorry for that, if you have your epicardium here, your myocardium here, and your endocardium here. Okay, so this is your coronary artery. Your coronary artery always supplies blood during diastole. That's when the heart relaxes. So your coronary artery supplies blood for into these three layers. So whenever there is reduced blood flow to the coronary artery, the supply here gets disrupted. As is the last structure to get your blood, this will be the first structure that will undergo damage when there is reduced blood flow. So this is what we call subendocardial ischemia, and this subendocardial ischemia will be seen on your EKG as an ST segment depression. What now you will say that what if the patient is elderly and he can't do cardiac stress test? So for that we have something we call pharmacologic stress test. So pharmacologic stress test uses drugs such as dipyridamole and silastazole. Let me write that down. Your dipyridamole and silastazole. These are your phosphodiesterase 4 inhibitors. So what they do is, let's say you have your coronary artery here and your plaque here. So what this drug do is that they cause them to vasodilate. So there is something called as coronary still. A phenomenon called as coronary still syndrome can be seen in this case. So what that does is that as the arteries already have a atherosclerotic plaque in them, they are maximally dilated, so they cannot undergo further dilation when you give them dipyridamole and silastazole. Whereas other coronary arteries that are healthy can undergo vasodilation when you give this drug. So they will go vasodilation, so they will take up more blood flow to their respective parts, and this atherosclerotic coronary artery will get even reduced blood flow, and at that time you can see the symptoms to the patient. And this along with your cardiac stress test can be used as a test for diagnosis stable angina. So stable angina is still a reversible injury to myocytes. As we know, there are two types of injuries to a cell. One is reversible and one is irreversible, in which the cell undergoes death. So reversible injury is seen in myocytes in case of stable angina. So even if you decrease the blood flow to your cardiac myocyte, they can still survive if when the blood flow is restored. So that this is all about stable angina. Now let's talk about unstable angina. So in stable angina, the patient was normal at rest. In unstable angina, the chest pain occurs at rest too. So the occlusion of a coronary artery is so much that the blood supply is reduced drastically to your cardiac myocytes. So the reduction in blood flow will manifest symptoms even at rest in this condition. The common pathophysiology behind this is that you have a rupture of atherosclerotic plaque near its neck, which leads to formation of thrombosis and incomplete occlusion of the coronary artery. So let me define that for you. So you have your atherosclerotic plaque here, and at its neck, it's weak. So what that means is that it can rupture anytime, and when it ruptures, the subendothelial collagen will get exposed, and this will attract platelets towards it and pathologically activate your coagulation cascade, resulting in a formation of thrombus over here. This thrombus will incompletely clog off these arteries, and the blood supply will be reduced drastically, resulting in symptom manifestation even when the patient is at rest. So this is the pathophysiology of unstable angina. It still is a reversible injury to the heart, as I have already told you what reversible injury is. And in this case, you see negative biomarkers. So what are biomarkers? Biomarkers are basically enzymes and certain molecules that are present within the cardiac myocytes. When the cardiac myocytes die, these molecules are released, and that can be tested in order to see if there is cardiac damage or not. So in this case, in unstable angina, the cardiac myocyte can still survive with a reversible injury. So there will be negative biomarkers such as your troponin, your I, and your CKMB. So this will not be seen in this case. What if you see this? So now you have what we call your NSTEMI. So that is your non-ST elevation myocardial infarction. So negative biomarkers, symptoms at rest, unstable angina. Symptoms at rest, positive biomarkers, and there is ST segment depression. That's your NSTEMI. So unstable angina has a higher risk of progression to myocardial infarction. So this thrombus can pathologically detach from here and can be converted into an emboli and can get clogged off into any other coronary artery, resulting in complete occlusion of that, and that can progress into myocardial infarction. Okay, let's talk about variant or Prince-Metal angina. So this is a phenomenon you see when the coronary artery undergoes vasospasm. So one of the highest yield association with this is with smokers. So smokers generally are the one who have this coronary artery vasospasm abruptly. Okay, this is episodic chest pain that is unrelated to exertion. What that means is that the patient can be lying down comfortably and all of a sudden abruptly can have these symptoms. In this case, you see a transmural ischemia. So let's see this illustrated here. This is your coronary artery, and when the patient has your variant angina, the coronary artery will undergo vasospasm. That means it will contract fully. So no blood can pass beyond the vasospasm. This can result in transmural ischemia. Transmural ischemia is a full thickness ischemia. So the endocardium, the myocardium, and the epicardium, all of them will not receive blood. So whenever there is transmural ischemia, you will see ST segment elevation in the EKG. This is relieved by your nitroglycerin and calcium channel blockers. Calcium channel blockers will cause the cardiac smooth muscle to vasodilate and not contract, thus ensuring that the blood flow is maintained. And nitroglycerin, as I said, reduces your preload to your heart, so your heart muscle won't need that much blood to work. And that's all about your Prince-Metal angina. Moving on to STEMI, or your ST elevation myocardial infarction. This is necrosis due to complete occlusion of the coronary artery. That means 100% of the coronary artery has been occluded. The lumen has been occluded, so there is no blood supply to this side of the cardiac myocyte. The patient will present with severe crushing chest pain, more than 20 minutes, that is radiating to his left arm and jaw. Along with that, pulmonary congestion can be seen, which will manifest as dyspnea. Again, the same mechanism as I said in during our stable angina uh, slide. There will be backup of fluid into the pulmonary circulation as the left ventricle is not working properly, and that will result in pulmonary hypertension and eventually dyspnea or difficulty in breathing. One characteristic feature of STEM is that the symptoms will not be relieved by rest as well as nitroglycerin, as is the full thickness uh, transmural infarction. The symptoms will not be relieved by nitroglycerin as the cardiac myocyte is already died. uh, in this case, you can do your cardiac enzyme test. One of the most specific and sensitive tests that you can do is your troponin I cardiac enzyme. So this is the first one to rise. It rises 2 to 4 hours after infarction and peaks at 24 hours and normalizes in 7 to 10 days. You need to remember these values, by the way. Okay, now let's say that you treat your patient who has ST elevation myocardial infarction. He goes home and he starts seeing the symptoms again, and he comes to your office. Okay, now you're confused whether this is the same ST elevation myocardial infarction due to the same coronary artery that was undergoing complete occlusion that resulted in the symptoms of this patient, or is this a new STEMI due to a different coronary artery, let's say. So how do you differentiate between this? For this, you can do another enzyme test, that is your CKMB or creatine kinase myoglobin enzyme, that is best for detecting reinfarction. So the logic behind this is that on day one, if the patient presented with ST elevation myocardial infarction, you did the troponin I test, the troponin I are high, you see that the cardiac myocytes are dead, and then you see the CKMB also. CKMB will rise after 4 to 6 hours and it returns to normal by 2 to 3 days. Okay, so let's say that the patient comes to your office on the 4th or 5th day with the same symptoms. Now you can't do troponin I test this time because it normalizes after 7 to 10 days. So in this case, you will do the CKMB test. If the CKMB values are high, that means is that the patient has a new ST elevation myocardial infarction, as after 2 to 3 days the CKMB will be normal in the patient who only had the recurrence of the original STEMI. And this is confusing, but just think about this. If the patient comes after 4 to 5 days with the same set of symptoms and the CKMB value is high, that means that the patient has a new ST elevated myocardial infarction that involves any other coronary artery apart from the one that was primarily there. Okay, if the enzyme does not rise, then this is the same ST elevation myocardial infarction. Okay, now let's move on to the treatment of this. You need to treat your patient with anticoagulants such as your aspirin and heparin. These are given to ensure that there will be no further clotting in the patient, okay, to make the patient anticoagulant. Along with that, as the cardiac myocytes are not functioning normally, your body will need oxygen. Also, the cardiac myocytes themselves will need oxygen, so you need to give oxygen therapy to your patient. Along with that, beta blockers can be given in order to decrease the cardiac contractility. And one of the other thing that you give beta blockers for is to avoid arrhythmia in the patients. So whenever there is myocardial infarction, the most common cause of death the myocardial infarction is due to arrhythmia. So in order to cancel out arrhythmia, you give beta blockers and you give nitrates, which will decrease the preload and eventually the workload of the heart. Now one mnemonic that you can remember for this is that Mona greets chest pain. So whenever patient comes to you with chest pain and you do EKGs and you see ST elevation, in this case obviously it's ST elevation myocardial infarction, so you will see ST elevation instead of ST depression. So a patient comes to you with chest pain, you need to give them Mona, greet them with Mona. So you give morphine for analgesic effect, oxygen, nitrates and aspirin. The definitive treatment for your ST elevation myocardial infarction is emergency angioplasty if done less than 90 minutes. So this is what we call your door to balloon time. It needs to be less than 90 minutes. If you're able to do it, then that's great. Do the emergency angioplasty. In this case, a percutaneous intervention is done. a catheter is placed, and that catheter has a balloon at its tip. So the balloon at its tip is inflated here. Okay, the balloon will undergo inflation, and that will cause the plaque to rupture, and the plaque will get destroyed, and the blood flow will get re-established. So this is the whole logic behind placing a stent. It will keep the artery open, and most of the stent are drug eluting. That means they have a covering of drug that is anticoagulant, so the stent themselves will not form more clots. So this is all about ST elevation myocardial infarction. Also, if the patient comes to you within, let's say if the patient comes to you and you diagnose them with STEMI, and that's within less than 30 minutes, then at that case you can also give them thrombolytics, such as your tissue plasminogen activator, which will activate your tissue plasminogen into plasmin being an antifibrinolytic. It will go and lyse the clot, ensuring that the blood flow is reestablished. So that is all about your ST elevation myocardial infarction. Let's talk about all the complications that you will see post myocardial infarction. So let's say you treat the patient successfully. Now we are saying that what will happen within the dead cardiac myocytes in that particular patient. So on the first day you will see coagulative necrosis. So I have this figure here. Let's say here the blood supply was totally cut to the cardiac myocytes, and the patient's heart muscles had coagulative necrosis in them. Okay, so coagulative necrosis is seen when you don't have any proteases active within the dead myocytes. So the myocyte will get coagulated and will present there for a while. Okay, you also have your liquefactive necrosis, which you will see when the blood supply to brain is cut. Along with that, you see that in your pancreatitis. Also in pancreatitis you see fatty necrosis. So you will get to know about the different type of necrosis in your pathology lectures. So for this, the cardiac myocyte will undergo coagulative necrosis on the first day. Then the inflammatory phase will occur from 4 to 7 days, in which during the initial days neutrophils will be the one who will dominate. As you know that neutrophils are the first mediators of your inflammation, and then followed by macrophages. So after that you see granulation tissues during the first and third weeks. From first and third weeks you see granulation tissue, and eventually it will heal by scar formation or fibrosis. As you know, your cardiac myocytes, your nerve cells, and your skeletal muscles are your permanently divided cells. What that means is, if this cell dies, they cannot heal themselves into 100% normal level. They cannot regenerate, is what I'm trying to say. Okay, they are permanently divided, so they can't regenerate. So they can only heal by fibrosis. So this is like a first copy brand that you take from market. So this will still not function as the original tissue, but still it will provide a structural support to the cardiac myocyte. Say you saw the infarction here, so this will heal all by formation of scar. This scar itself will not be functional, it will just support the surrounding structure. So this we will discuss this slide by slide. Okay, now let's see what happens during the first days after your myocardial infarction. So you will see inflammation that is dominated by neutrophils during the first few days. It will give it a characteristic yellow pallor. You will see a complication that can occur during this time is what we call fibrinous pericarditis. This will only be seen when there is transmural ischemia to the heart tissue. Okay, so when all the three layers of your cardiac myocytes are dead due to the complete stop of blood supply, at that time you see fibrinous pericarditis, in which in this what happens is that the neutrophils will continue on inflammation and clearing out all the dead cells. Along with that, the system will undergo haywire, and the neutrophils will extend the myocardial inflammation until the pericardium. So the sac that covers the heart, the inflammation due to neutrophils will go from this to the very end, to the pericardium. Okay, this will present as chest pain with friction rub. And just a reminder, this is only seen when there is transmural or complete full thickness inflammation, not when there is subendocardial or subtotal ischemia. So this will present with chest pain and friction rub. The theory behind friction rub is that when the pericardium and the epicardium, they both touch each other, there will be characteristic friction rub that you can see on auscultation. Now let's see what happens during the 4 to 7 days. After neutrophils, macrophages are the second corresponders to your inflammation. So macrophage predominant will be there. It will again show yellow pallor. The patient is at risk for ventricular free wall rupture, which can lead to cardiac tamponade. Now let's discuss it here in this figure. So let's say your left ventricular wall was the one which got infarcted, and there is transmural ischemia. All the cardiac myocytes here are dead. Macrophages will come after neutrophils here, and they will secrete some proteolytic enzymes here, which will cause this wall to get weakened. So if there is stress on this wall, let's say if the left ventricle needs to contract strongly and there is pressure on this wall, this can lead to rupture of this wall, eventually leading to all the blood being accumulated within the pericardial sac. So all the blood will be accumulated here, and this condition is what we call cardiac tamponade. Okay, cardiac tamponade means that there is free blood present within the pericardial sac. This will have further complication which can lead to death in the patient too. One other complication that you can see is intraventricular septal rupture. So this can be seen here. Same thing, the macrophages comes, they secrete some proteolytic enzyme, this will get weakened out and eventually it will rupture. So as we know that the left ventricle is highly contractive as compared to the right ventricle, so the contractility force of the left ventricle is greater, so the blood will flow from left ventricular tract to right ventricular tract, and this will further create complication. And the last thing that you can see is papillary muscle rupture. So this is your mitral valve, and these are the papillary muscles that's holding mitral valve here. So if there is papillary muscle rupture, again the same mechanism, due to macrophages, the valve will not be able to close properly, and the blood will start to leak out into the left atrium. So there will be mitral regurgitation that can be seen in this case, and eventually leading to backup within the system. Here are your lungs, let's say. So you will see pulmonary congestion and many more complications. Now moving on to, after 1 to 3 weeks, you will see predominance of granulation tissue. This is basically when you see your extracellular matrix trying to deposit or trying to heal the dead tissue by formation of your scar. So this will present with lots and lots of blood vessel trying to supply the healed part of your cardiac myocytes. So in this case you can see plum fibroblast and granulation tissue. Now let's talk about what will happen months after myocardial infarction. So you can see a classic white scar. So in this case we had your infarction at the left ventricular wall. So this will get healed up by formation of scar and fibrosis. So one complication that you can see is aneurysm. This new healed scar part of the left ventricle is not as strong as its original counterpart. So this will eventually undergo weakening and dilatation. This is like a balloon. So when there is blood pressure here, the scar is not that strong, so this tissue will undergo balloonation. This is what we call aneurysm. After that you can see mural thrombosis. So whenever this aneurysm, the blood tries to be stagnant there, the blood being stagnant can activate the coagulation cascade, and which can result in formation of a thrombus. Okay, so this is one of the complication. One last complication that you can see after that is Dressler syndrome. So in Dressler syndrome, it also needs to have a transmural inflammation in order to occur. So the logic behind is that whenever there is transmural inflammation that extends to the pericardium, the pericardial antigens can be taken up by your immune cells and can be presented to the immune system. And the immune system after months can produce, after processing the antigen, it can produce antibodies against the pericardium, and that can lead to inflammation. Basically your body is attacking your heart, is what Dressler syndrome is all about. So get to know the difference between Dressler syndrome and your fibrinous pericarditis. Okay, Dressler syndrome will present months after and fibrinous pericarditis will present days after. That's the difference. Now let's talk about heart failure. First, let's talk about left heart failure. So left heart failure is seen when the left ventricle is not able to push forward the oxygenated blood into the system. So the failure of the heart to push forward blood is what's called heart failure. This can be caused due to ischemia, as ischemia can result in death of cardiac myocyte, formation of scar tissue. Those scar tissue won't function normally, so the overall left ventricle will not be able to function normally. Also, dilated cardiomyopathy can result in heart failure. So dilated cardiomyopathy is basically when your left ventricle undergoes your eccentric hypertrophy, which will cause the lumen to increase but the cardiac muscle strength to decrease. Okay, so it will store lots and lots of blood, but the forward perfusion will be reduced. Okay, and when there is hypertension, the cardiac muscle can undergo concentric hypertrophy. It's also called heart failure with preserved ejection fraction. In this case, the left ventricle muscles will undergo hypertrophy. Okay, when there is increased mean arterial pressure, which causes the heart to push harder. So the heart muscle will get concentrated, will get hypertrophied, and eventually having concentric hypertrophy. The heart muscle will be able to withstand the force and will be able to counter the force and push the blood into the systemic circulation. This will again eventually fail, and the heart muscles will be so stiff that the lumen size will be decreased and the blood flows that the left ventricle can normally store will be decreased. So there will be again decreased forward perfusion of the blood flow. And heart failure can also be caused due to myocardial infarction, as seen here. Now let's talk about the clinical consequences of left heart failure. You see pulmonary congestion due to left heart failure. Again, the fluid will get backed up into the left atrium and then to the pulmonary circulation. You will see pulmonary congestion. You see characteristic heart failure cells. So whenever you see heart failure cell, you have to think about left heart failure. So the whole idea behind this is that this is your left ventricle, this is your left atrium, and your lungs. Let's say these are your lungs. Okay, they drain into your left atrium. So when there is left ventricular dysfunction, the blood will eventually get backed up into the left atrium, then eventually get backed up into the lungs. In the lungs, there are pulmonary capillaries. The high pressure to pulmonary capillaries can cause the pulmonary capillaries to burst open. So all the blood that inside the pulmonary capillaries will go into the extracellular spaces. Here the macrophages will engulf them, and you can see characteristic heart failure cells or hemosiderin laden macrophages. Okay, they are also called your hemosiderin laden macrophages. So one other clinical consequences of left heart failure is your renin-angiotensin system overactivation. So when there is heart failure, there will be obvious decrease in the perfusion of blood to every organ, the kidney also being one of them. So decreased blood flow to the kidney will think that the system is not having enough blood, so it will activate the renin-angiotensin aldosterone system. So basically your aldosterone 2 will get activated along with renin. It will retain a lot of water and your sodium, water in a greater amount to your system, eventually leading to high blood pressure. So this is where the problem is. You already have a heart failure situation, so the blood is already being backed up in the system and the kidney is trying to retain more fluid into the system. so the condition gets worsened in this case. That's why the mainstay treatment is use of ACE inhibitors. So these are your drugs that ends in pril. So your captopril, lisinopril, those can be used. So ACE inhibitors, basically angiotensin 1 is converted into your angiotensin 2 with the help of angiotensin converting enzyme. ACE inhibitors inhibits this enzyme, so angiotensin 2 will not get formed and it will not be able to do its job, okay, which is to retain water. Now let's talk about right-sided heart failure. The most common cause of a right-sided heart failure is a left heart failure. So the logic behind this is that when you have your left heart failure, this will eventually cause the backup of fluid into the left atrium, then the lungs, okay, and then eventually it will go into the right ventricular tract, and the backup will lead to congestion and eventually it will lead to right-sided heart failure. So most common cause is due to left heart failure. Also, you can see right-sided heart failure in something that's called a left to right shunt. In left to right shunt, for example, if the patient has a ventricular septal defect, so ventricular septal defect, there is a gap in the interventricular septum between the right ventricle and the left ventricle. So the blood will first start to flow from left ventricular to right ventricular, as the left ventricular has high contractility and more number of cardiac myocytes that contract. The left ventricle will push blood into the right ventricle. This eventually will result in your pulmonary hypertension. Pulmonary hypertension will cause the left ventricular to undergo hypertrophy. It will hypertrophy, and eventually the flow of blood will get reversed. So after some time you will see the right ventricle pushing blood into the left ventricle, and eventually that system will also get failed, resulting in your right-sided heart failure. This syndrome, in which a left to right shunt will eventually cause a right to left shunt, is also called as Eisenmenger syndrome. So remember this too. Then due to pulmonary hypertension, you see right heart failure. This condition is called as cor pulmonale. And clinical manifestation of right-sided heart failure, you need to know this. So you see jugular venous distension. So let's say the superior vena cava and the inferior vena cava drains into your right atrium. So due to right ventricular failure, the fluid will get backed up into the vena cava, and you can see the right heart failure manifestation when you see a jugular venous distension in your patient. Also, hepatosplenomegaly can be seen, and a characteristic nutmeg liver can be seen. So this is seen when there is right heart failure. So the fluid backs up until the hepatic vein, and this causes congestion of the liver too, resulting in characteristic nutmeg appearance. And last, you will see a dependent pitting edema. So one thing you need to remember is that whenever the capillaries or your arterioles, whenever they are damaged, either due to inflammation or due to increase in hydrostatic pressure or due to decreased oncotic pressure, you can see edema. Okay, so now how to determine whether the edema is due to leakage of protein or due to high hydrostatic pressure? You can just simply press on the edematous part. If the edematous part undergo pitting edema, then most likely it's due to high hydrostatic pressure, as proteins cannot be indented, but water can be. So due to the buildup of fluid into the tract, the hydrostatic pressure will increase and it will result in a dependent pitting edema. And that's about this module. Thank you for your time.